Welcome back, everybody, to our second online class in primary care. Today we'll be talking about health promotion and prevention. Everyone defines health differently. One may be more concerned about their physical, mental, or emotional health. Our job as doctors is to promote overall well-being. We will talk about the 3 preventable causes of death and then define the 4 different types of prevention. We will go through each recommendation by USPSTF for a well woman exam. Lastly, we'll talk about the Choosing Wisely campaign that helps us make safe decisions for our patients. More than 70% of diseases are preventable. Most people with chronic diseases are asymptomatic. Early detection is associated with higher cure rates, which results in better health, quality of life, increased productivity, reduced healthcare costs, and it actually saves lives. These are all the great benefits of prevention, but it does come at some cost. The harms of screening tests could be resulted in false positive and false negative results, which can create unnecessary anxiety, including unnecessary tests and biopsies or overdiagnosis. There has to be a balance between the benefits and harms. Most of what we do as doctors is try to prevent diseases. We have been most successful at primary prevention, which is intervening before the health effects occur. A prime example of this is the administration of immunizations. By doing this, we have eradicated many childhood diseases. Secondary prevention is screening asymptomatic patients to identify the disease in its earliest stage. Screening mammograms to identify breast cancer and blood pressure checks to identify hypertension are the examples. Once the patient is diagnosed with a disease, managing the disease to slow or stop its progression would be tertiary prevention. The new concept of prevention that's gaining a lot of attention now is called quaternary prevention. This embraces the concept of first do no harm. It has a set of health activities to mitigate or avoid consequences of unnecessary or excessive intervention of the healthcare system. Examples are the indiscriminate use of antibiotics, doing a pap smear in a woman greater than 65 years of age, or mistaking a risk factor for disease. For example, high cholesterol does not equal coronary artery disease. Many organizations have joined the Choose Wisely campaign and set guidelines for us to keep our patients safe. I encourage you to look up some of these guidelines, but we will also address some of them during this lecture. As providers, we promote health through counseling and patient education. Counseling is a very difficult skill to acquire because you have to read the patient correctly. Then you know to either soft sell your recommendation or take a very direct, authoritative role. Most of the time, you have to negotiate and individualize each counseling for that patient for those diseases. The USPSTF recommends to discuss prevention at each individual visit. We also have to risk stratify our patient based on age, sex, family history, socioeconomic status, their lifestyle choices. All of this information helps us counsel our patient to help make the best decision for them. When counseling a patient, we have to be very clear to define the health risk. For example, if you're counseling a patient about smoking cessation, clearly state smoking causes lung cancer. You then should assess how ready are they to make that change. We should advocate and command any behavior change. If they cut down their smoking by a few cigarettes or attempted to quit, recognize it and congratulate them. Assist them in identifying the target behavior. What are the barriers? What are the benefits? Reinforce health benefits to the behavior change. In this example, if you quit smoking, you will reduce your chance of lung cancer. You will reduce the risk of emphysema. Make sure to offer resources, strategies, and support. Give them a clear plan of action and monitor their mechanism. If a patient's obese, we can't just say lose weight. Bring them back for a weight check in a month, or just give them a phone call. See how they're doing with that plan of action that you formulated together. Unfortunately, there's many healthcare system barriers, limited resources to address these prevention, and then time and reimbursement. The United States Preventative Service Task Force is an independent panel of 16 primary care and preventative experts. They give us recommendation for screening tests, immunization, counseling, preventative medications. They rigorously evaluate current evidence to assess the benefit and harm for every intervention. I highly recommend downloading the app, as you can put in your patient demographics and it will give you all the screening interventions you should perform at that visit. In addition, the screening tools are there, the rationale, and the clinical considerations. Each intervention is graded based on the evidence. Grade A recommendation means there's high certainty that the net benefit is substantial, therefore we should offer and provide the service. Grade B recommendation means that there's high certainty that the net benefit is moderate, or there's moderate certainty that the benefit is moderate to substantial. Again, you should offer and provide the service. Grade C recommendation has moderate certainty that the benefit is small. The USPSTF recommends offering or providing the service only to selected patients depending on their individual circumstances and with the proper counseling. Grade D recommendation has moderate or high certainty that the service has no benefit or that the harm outweighs the benefit. This recommendation is discouraged and these services should not be provided. Our recommendation just has insufficient evidence to recommend for or against. If these services are offered to a patient, that patient should understand the balance of benefits and harm and the uncertainty of the data. Health insurance coverage is based on these guidelines. The Affordable Care Act requires that the USPSTF Grade A and B recommendations be covered by insurance. So what are the leading causes of death in the United States? In 2016 to 2017, the CDC has heart disease, cancer, and unintentional injuries as the top 3 leading causes of death. Interestingly, the leading causes of preventable death and illness is tobacco, obesity, and alcohol. We should address these at each visit if we want to make an impact on the individual and the public health at large. We will go over the recommendations by USPSTF for each one of these. It is an A recommendation that clinicians ask all adults about tobacco use, advise them to stop using tobacco, provide behavior intervention, and prescribe FDA-approved pharmacotherapy for cessation. The same is true to ask all pregnant women about tobacco use, advise them to stop using tobacco. There's no amount of cigarette that is safe in pregnancy. Unfortunately, we have insufficient evidence to offer pharmacotherapy, and this is an I recommendation. Tobacco use is the single greatest modifiable risk for cardiovascular disease. Smoking confers an additional 25% cardiovascular risk in women. It's the leading cause of death in women. It has negative effects on fertility and fetal development. It has known cancer link to lung, colon, and breast. It causes the progression of cervical cancer independent of HPV. For all these reasons, we should encourage women to stop smoking. However, it's harder for women because they have intense withdrawal symptoms. They have greater susceptibility to sensory triggers such as taste, smell, and social cues. Nicotine replacement therapy is less effective in women because they metabolize nicotine faster. Although women are less likely to initiate smoking, they're more likely to relapse. They are also more concerned about post-cessation weight gain. So if we address this weight gain, they're more likely to stop smoking. Knowing these unique differences between men and women shall help us promote and advocate for women even more effectively. So what are the treatment options for smoking cessation? Nicotine replacement therapy works independent of its delivery system. There is gum and patches that are over the counter. You can give it as a nasal spray or inhaler, which are prescribed. But first-line FDA-approved treatments are Zyban and Chantix. It is not clear how Zyban works, but they think it is independent of its antidepressant effects. Zyban is contraindicated in patients with eating disorder, seizure disorder, and severe head injuries, as it lowers seizure threshold, and it has an eye recommendation in pregnancy. Chantix reliably increases long-term smoking abstinence. It is more effective than Zyban, but also more expensive and harder to get approved by health insurances. The black box warning for suicide and vivid dreams have been taken away, and it is thought to be safe now. Other treatment options are psychosocial therapy and behavior therapy. Medicare has some coverage for counseling as well as quitting smoking through medication or counseling. The Affordable Care Act mandates that all Medicaid programs cover tobacco cessation medications for all individuals and counseling for all pregnant women. The 5 A's are a quick screening tool to ask, do you smoke? Advise the patient, smoking is bad for your health. Assess their readiness by simply asking, are you ready to quit today? You can assist by asking them if they would like a prescription, a nicotine replacement, or Zyban, and then arrange a scheduled follow-up in 1 week, as we know that most patients relapse within a week. Counseling is effective even if it's as little as 3 minutes by a physician. Medication and counseling are effective on their own, but of course in combination, even better. Telephone quit lines do help. They're free. You have a trained counselor. Although a Cochrane review showed it had no proven benefit over nicotine replacement, they do help with smoking cessation. Obesity is something we see every day but very difficult to address. It is a B recommendation that we refer patients with BMI greater than 30 or higher to an intensive multi-component behavior intervention. This is because we know excessive weight gain has direct cardiovascular risk factors. We know that healthy eating and exercise is the best way to prevent obesity or to help obese patients lose weight. This is why we should refer our patients to nutrition, even with BMIs greater than 25. We should also be clear about how much exercise they need to get. The recommendations for aerobic exercise is 150 minutes of moderate intensity, 75 minutes of vigorous intensity per week. Muscle strengthening every week of all major groups, 2 or more days in that week. Most patients find this overwhelming, and it is important that we reinforce any level of exercise reduces diabetes, cardiovascular risk, independent of weight loss or what your BMI is. Other additional benefits, it reduces breast cancer, colon cancer, osteoporosis, dementia. For women who have symptoms of fibromyalgia, depression, insomnia, chronic pain syndromes, it also decreases these symptoms. Again, it's not enough just to say, go ahead and lose weight. Bring them back for a weight check in the clinic. Give them a phone call a month later and see how they're doing with the regimen. Alcohol use and misuse is common because it is easily accessible. The USPSTF recommends screening all adults greater than 18, including pregnant women, for alcohol misuse or abuse, but also providing interventions. There are 2 screening tools, CAGE and Audit. The difference where Audit also is screening for dependence and hazardous consumption of alcohol. It is also internationally validated. We are currently using the 4 Ps in our clinic system for alcohol screening in our initial OB visit, 2nd and 3rd trimester. There is an acceptable range of alcohol consumption. For women, this is less or equal to 1 drink per day. Heavy drinking would be greater than 1 drink per day. Most common form of excessive alcohol consumption is binge drinking, which would be defined 4 or more drinks during a 6-hour period for a woman. It is also important for us to know what is a standard drink. In the diagram, you can see that 1 can of beer, 1 glass of wine, and 1 shot of hard liquor is called 1 drink. Screening and referring patients to appropriate intervention is necessary if you are concerned for alcohol abuse or misuse. It was stated earlier that the leading cause of death in the United States is cardiovascular disease. So do we screen for this or atrial fibrillation by EKG? The answer is no. This is a D recommendation. You should not order a resting or exercise EKG to prevent cardiovascular events in asymptomatic adults who are at low risk for cardiovascular events. So how do we address the morbidity and mortality caused by cardiovascular disease? Well, we treat the risk factors. As we had discussed, tobacco increases cardiovascular risk by 2 to 4-fold. So addressing smoking cessation with our patients, physical inactivity, which leads to obesity and putting a strain on the heart, healthy eating, as we know high saturated fats are linked to heart disease, as well as treating other risk factors such as high cholesterol, hypertension, and diabetes. And then, although rare, looking for hereditary causes of cardiovascular disease. So who, what, and how often should we be screening? For blood pressure, we should screen patients older than 18 about every 3 to 5 years. If a patient is older than 40, you should consider screening every year, or if they're considered a higher risk. For patients who have a high normal blood pressure, 130 to 139, over 85 to 89, obese, overweight, or African Americans. If a blood pressure is elevated in clinic, it should be confirmed with ambulatory blood pressures before treatment is started. This is a recommendation. For diabetes, you should screen all patients aged 40 to 70 with a BMI greater than 25. This is done every 3 years. If a patient is younger than 40 with known family history of diabetes or considered to be in the high-risk groups, screening should be done more frequently, ideally on a yearly basis. A hemoglobin A1C, a fasting glucose, or a 2-hour oral glucose challenge test with 75 grams of sugar is what's recommended. This is a B recommendation. For high cholesterol, patients aged 40 to 75 should be screened. There's no known interval, but of course, if they have high cholesterol, they should be started on a statin for cardiovascular risk greater than 10%. Cancer was the second leading cause of death in America. For women, this would be breast cancer as the most common cause of cancer. The second leading cause of death for women, 1 in 8 women we know will develop breast cancer. BRCA1 and 2 occur about 1 in 300 to 500 in the general population. There's many different screening guidelines, USPSTF and ACOG, which we will focus on, but almost everyone has a say in breast cancer recommendations. We discussed mammogram being an example of secondary prevention, screening asymptomatic women to pick up the disease at its earliest stage. So when does the USPSTF recommend screening mammograms? The B recommendation is to start at age 50 to 74. They recommend biannual screening, as biannual screening is optimal. It preserves most of the benefit of annual screening, but cuts the harm in half. What about screening starting age 40? This is a C recommendation, and the counseling should be individualized. This is for women who place a higher value on the potential benefit than the potential harm. Screening at age greater than 75 is an I recommendation. So how do you help the patient make a decision? And how do you analyze that decision making? The best way to put it to the patient is to ask, how many 40-year-olds who start having screening mammograms every 2 years will die from breast cancer in the next 10 years, and that is 2 per 1,000. The opposite question is how many 40-year-old women who do not have screening mammograms every 2 years will die from breast cancer in the next 10 years, 2.5 per 1,000. This may be easier for the patient to digest. The other way to analyze it is to look at the reduction of mortality. If mammograms were started at age 50 to 69, there's a 17% reduction in mortality. Extending the age range produces only a minor improvement, an additional 3% starting at age 40 and 7% extending it to age 79. Remember, your counseling is very important and the decision should be individualized. Screening mammogram is not the only breast cancer screening method. Breast self-examination has not shown clear benefit of cancer screening. Clinical breast exam has insufficient evidence to recommend a singular modality. Randomized controlled trials demonstrate varying detection rate, anywhere between 3% to 57%. Only about 5% of breast cancers are found on clinical breast exam. Breast MRI is recommended for patients that are higher risk for breast cancer, such as patients with BRCA1 and 2. However, MRI impact on breast cancer mortality is uncertain. Different organizations have different recommendations. ACOG specifically recommends mammogram and clinical breast exam annually at age 40. There's no consensus on the upper age limit, and they encourage that all women should practice breast awareness. The USPSTF recommends that we refer patients for genetic counseling if they have a personal or family history of breast, ovarian, tubal, or peritoneal cancer, or if they have an ancestry that increases their risk for BRCA1 and 2 gene mutations. If the history is positive, then it is recommended that you use an appropriate brief familial risk assessment tool, as you see on the right. What about cervical cancer? I assume you know the current guidelines for screening. But what I want to talk about is the Choosing Wisely campaign and what we should not be doing. Remember, this is quaternary prevention. First, do no harm. We should not be performing pap smears or HPV screening in patients who had a hysterectomy with the removal of a cervix and have had no history of high-grade dysplasia, SIN2 or 3, or cancer. We should not doing PAPs or HPV screening in patients younger than 21 who have a normal immune system. ACOG recommends to not perform routine annual pap smears in women aged 30 to 65. All these recommendations are to prevent unnecessary testing in our patients. Many patients will ask to be screened for ovarian cancer. What makes it difficult is that the symptoms of abdominal pain, bloating, and constipation are too nonspecific for risk stratification. Screening does not reduce ovarian cancer mortality. Harms from screening are at least moderate and may be substantial, requiring unnecessary surgery. This is a D recommendation, as the harms may be more than the benefits. The Choosing Wisely campaign does not recommend screening for ovarian cancer with ultrasound or CA-125. One way to address this with your patient is to encourage them to have children younger than 35, breastfeed greater than 18 months, and if they're considering tubal ligation, to have a total bilateral subpingectomy to reduce ovarian cancer risk. How about screening pelvic exams in women for early detection and treatment of a range of gynecological conditions? Well, the USPSTF says there's insufficient evidence to screen asymptomatic non-pregnant adults who are not at increased risk for any specific gynecological condition. They do clearly state that it's fine to do pelvic exam for screening pap smears, or if a woman presents with pelvic pain, vaginal discharge, it's fine to screen for gonorrhea and chlamydia. For colorectal cancer screening, there's a number of tests that are equally acceptable. The recommendations focus on being screened as opposed to which tests need to be used. Screening should start at age 50 to 75 with a high sensitivity fecal occult blood testing, sigmoidoscopy, colonoscopy. The 10-year life expectancy should be considered, as risk for colonoscopy increases with age and comorbidity. For this reason, screening patients between 76 to 85 years of age is a C recommendation. Adults in this age who have never been screened are likely to benefit. Do not screen patients greater than 85 years of age. There are 3 stool-based tests. The FIT test has improved accuracy over the guaiac fecal occult blood testing. It can be done in a single specimen, but needs to be repeated every year. The nice thing about stool-based tests is that they do not require bowel preparation, anesthesia, transportation to and from the exam room, and they can be done at home. The FIT DNA test, also called the Cologuard, is done every 1 to 3 years. The disadvantage is that it has more false positive results, requiring more diagnostic colonoscopies. There is insufficient evidence about appropriate long-term follow-up of abnormal findings as well. We also have the option for direct visualization tests, colonoscopy being the best and most commonly used. It has prospective cohort studies with mortality endpoints. It requires less frequent screening and can be done in 10-year intervals. The advantage is that screening and diagnostic follow-up for a positive result can be performed at the same time. CT colonography can be done every 5 years, but there's insufficient evidence about potential harms of associated extracolonic findings, which are common. Flex sigmoidoscopy can be done every 5 years. If done with a FIT test, it can be done every 10 years, plus the FIT test on a yearly basis. Flex sig is less available in America, as less people and providers are actually performing this test now. So how do you decide who to screen and when to screen? This is an algorithm by the American Gastroenterology Association. If a patient is symptomatic with rectal bleeding or changes in caliber stool, then you should proceed to diagnostic workup, usually with a colonoscopy. If a patient is asymptomatic and less than 50 years of age with no family history of colorectal cancer, screening is not required. If the patient is greater than 50 years of age without family history of colorectal cancer, they are considered average risk and can be offered a number of the screening tests we discussed. If a patient is less than 50 or greater than 50 but have a positive family history, mainly 2 or more first-degree relatives affected with colon cancer or first-degree affected at age less than 60, then screening colonoscopy should begin at age 40 or 10 years than the youngest person that was diagnosed in that family, whichever comes first. Again, from the Choosing Wisely campaign, the AGA recommends to not repeat colon cancer screening by any method for 10 years after a normal high-quality colonoscopy. As discussed earlier, women have unique characteristics that make it difficult to stop smoking. Smoking is primarily a risk factor for lung cancer, accounting for 85% of all cases. The incidence of lung cancer increases with age, the most common being greater than 55. It is a B recommendation that we screen patients annually with a low-dose computed tomography. In adults aged 55 to 80 who have a 30-year PAC smoking history and are currently smoking or have quit within the past 15 years. Screening can be discontinued once a patient has stopped smoking for more than 15 years or develops a health problem that substantially limits their life expectancy. When is the last time you ordered a DEXA scan? We have the unique position of treating and caring only for women. One of the most important things we can do is prevent osteoporosis. Osteoporosis is defined by the WHO with a bone mass density less than 2.5 from the standard deviation. The hip DEXA is the best predictor of hip fracture and is the most clinically relevant site of fracture. The prevalence increases dramatically with age. Most women are asymptomatic until a fracture occurs. The main goal is to prevent a fracture by screening and drug therapies. An osteoporotic fracture, especially the hip, limits ambulation, chronic pain and disability, loss of independence, decreased quality of life. The 1-year mortality is as high as 30%. Women at every age have higher rates of mortality compared to men. Women 65 and older should be screened for osteoporosis with a DEXA scan. Women younger than 65 that are increased risk for osteoporosis should also be screened to prevent osteoporotic fractures. Women at increased risk are those with lower BMI, excessive alcohol consumption, currently smoking, long-term corticosteroid use, which means more than 3 months, those with previous fractures, or a history of falls within the past year. There's no information currently available on the frequency of DEXA scans. Generally, they can be done every 2 to 3 years due to the slow bone remodeling. The USPSTF recommends that we use the FRAX tool to assess the risk for osteoporosis. It is based on clinical risk and bone mineral density of the femoral neck. It is specific for every country and race. By putting the patient's demographics, you can get the 10-year probability of hip fracture, as well as the 10-year probability of major osteoporotic fractures that have clinical significance, such as the spine, forearm, hip, or shoulder fractures. Which sexually transmitted infections should we be screening for? HIV screening is now recommended from age 15 to 65, younger or older if they have additional risk factors. About 10 to 25% of patients who are HIV positive report no high-risk behaviors. Young people are likely to be unaware of their status. More than 20,000 infections have been transmitted by unaware people. Screening tools are cost-effective, even in low-risk communities. We now screen for HIV regardless of risk factors because we have moved from risk-based to routine screening. This benefits the individual and the public health. There is insufficient evidence for optimal interval for screening, but you can try screening at least every year since somehow, in some way, everyone is at risk. Hepatitis B screening is recommended for non-pregnant adolescents and adults at high risk. High-risk groups include U.S.-born person not vaccinated as infant whose parents were born in regions of high prevalence of HBV. This includes sub-Saharan Africa, Southeast and Central Asia. Persons born in countries and regions with high prevalence of hepatitis B infection are also considered high risk. Other high-risk groups include men who have sex with men, HIV positive, IV drug use, patients on hemodialysis or immunosuppressive therapy, household contacts of persons with hepatitis B infection. One-time screening for hepatitis C is also recommended for patients 18 to 79. Periodic screening is also recommended for persons with continued risk, such as past or current injection drug use. There's a rapid increase in hepatitis C in ages 20 to 39, but mainly in American Indians, Alaskan Natives, and non-Hispanic whites. Another group to consider screening is the baby boomers. 1 in 30 of baby boomers are infected, and 75% of these cases can be cured with treatment. Syphilis screening is also recommended for adolescents and adults at increased risk. Males younger than 29 are now considered a high-risk group because they have the largest number of infections. The frequency of screening is unknown. Initial studies for men who have sex with men and HIV-positive patients show an additional benefit for screening patients every 3 months. This is a map of the United States showing primary and secondary syphilis as of 2017. The dark blues represent higher rates of infection. Again, this is usually in young men less than 29 years of age. Finally, we'll talk about immunization, which is the best form of primary prevention. Influenza should be given yearly to patients greater than 19 years of age. Tdap can be given every 10 years in a non-pregnant woman. Zoster is for patients age 50 and older, usually requires a 2-dose series. HPV can be given from age 9 to 25. However, recently the FDA approved to give it to women aged 27 to 45, but this needs to be based on shared clinical decision making. There are 2 types of pneumococcal vaccine, PCV13, which is called Prevnar, and PPSV23, called Pneumovax. PCV13 is normally given as part of the childhood immunization series, but now it's also given to adults to enhance the protection of pneumococcal infection and pneumonia. This is usually mediated by T-cell response, as compared to PPSV23, which has a B-cell response. Pneumovax confers 90% protection against pneumonias with susceptible strains. The first dose of PPSV23 can be given at age 65 or older. If the first dose was given at age younger than 65, then you have to administer PPSV23 at least 5 years after the previous dose. If PCV13 is to be given, it should be administered first and at least 1 year apart from the PPSV23. Indications for these vaccines include chronic medical conditions such as chronic heart disease, lung, liver, diabetes, or cigarette smoking. The best way to conclude this lecture is give you a list of do's and don'ts. So please, don't screen for cardiovascular disease and atrial fibrillation by EKG. Do not screen for ovarian cancer by pelvic exam, ultrasound, or CA125. Do not do screening pap smears in women younger than 21 or older than 65. Do not screen with HPV for women younger than 30. Do not do screening pelvic exams for gynecological conditions. But please do screen for hypertension, diabetes, cholesterol. Screen for breast cancer in women aged 50 to 75 by mammogram. Screen women aged 21 to 65 for cervical cancer by doing a pap smear. Screen for colorectal cancer in age 50 to 75 by any of the modalities we talked about. Screen for lung cancer by doing a low-dose CT scan if the patient meets the criteria. Order a DEXA scan in women older than 65 and younger women at increased risk for osteoporosis. Screen for HIV in patients aged 15 to 65. Screen for syphilis for those patients that are at risk. Screen 1 time for hepatitis C in high-risk populations and in baby boomers. Screen for hepatitis B in high-risk groups as well. Since we don't have to do breast exams and pelvic exams anymore, we technically have more time to screen and address at least the 3 modifiable risks that cause so much disease: smoking, obesity, and alcohol. I encourage you to look at the Choosing Wisely campaign so we can avoid any unnecessary harm to our patients. Thank you.